colleagues, cheers. Welcome to PT Pintcast. We're excited. It's happy hour somewhere, hopefully in my living room. And look at that. That's where we are. What's up? I'm Jimmy McKay. I'm your host for PT Pintcast, a podcast that saves physical therapists from missing out on amazing insight, remarkable ideas, and motivational stories here in the world of physical therapy. We've got a great show for you tonight. I'm very excited about this. Putting a little different spin on the ball. Sort of a panel, but like nothing you've kind of experienced before. And it started with a tweet. Doesn't it always? Well, usually it's like some Twitter flame war or something. This did not devolve. This evolved. We got smarter when we were done with this Twitter conversation. I guess really we wanted to talk about like how do you respond to the idea of death, right? It's a part of life. All of them. But how do you respond appropriately? And when you're confronted with it, how do you respond? I think most people, myself included, you sort of like kind of get smaller and quieter. Maybe you feel uncomfortable about talking about it. But what do we know about not talking about something? Well, it gives it power. We don't want to do that. So if you're working with a patient, what do you do if they ever said, I'm ready to die? Well, that's exactly what happened. So let's bring our first of very few guests tonight. Let's bring her to the studio, a PT student, Shelby Miller. Shelby, welcome to the show.
Hi, thank you.
Shelby, let's get your quick backstory. First of all, first questions are always the hardest. What are we drinking tonight? You're a PT student. You have to have something.
Unfortunately, I'm just drinking water tonight.
Yeah. Your professors are watching this. I get it.
That's right.
You're going to play it cool. I got it. Great. I'm going with a Mick Ultra because it's mostly water. I'm hydrating while I'm dehydrating. So wanted to say thanks to our sponsors, Owens Recovery Science, Johnny Owens and the team. A single source for PTs looking for certification and personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com. BFR, as the cool kids are calling it these days. Kind of a thing. I get lots of people asking me about BFR. You guys cover that in PT school just yet?
We've talked about it, but we haven't really covered it yet.
It's come up. And where are you a PT student? Where do you go to school?
So I go to Clarkson University up in northern New York, in Potsdam, New York.
Just call it Southern Canada, and we'll just call it.
That's right. It is.
All right. So what year are you, Shelby?
I'm a second year.
Second year. Wow. Right in the middle. So you're on the hump, I guess. It's like hump year because you're there. You survived the first. You're up the hill. Now you feel like Sisyphus.
Yep.
You get to roll down the back of the hill.
Yep. We're at the hardest semester, and it's just going to go downhill from there.
There you go. That's the way to look at it. All right, Shelby. So where did this conversation start? I mentioned it started on Twitter. So let's throw I'll throw the graphic up. And this is what I came across. And I'm like, I think a lot of people on Twitter, where typically I'll just kind of be cruising around on the phone and I'll spot something. And then I'll either like get super excited about it, like super pro, or I'll be like super anti. And then I do what a lot of people do. I just dive into the comments and watch what everybody else is saying. And then I'm like, I shut my phone and I slam it down. Your tweet did not do either of those things. Yours caught my attention, and I'll throw it on the screen right now. This was your tweet from a couple weeks ago. And for the podcast audience, I won't leave you out. It says, how do you respond to a patient who tells you they're ready to die? You went on to say you encountered this situation today, and you were at a loss for words. Shelby, I would have been at a loss for words too. Any wisdom? P.S. You were in acute care. Now, was this a rotation? Was this like an integrated rotation, or was this a full-time rotation? What is it?
This was my first full-time rotation towards the end of my acute care rotation back in October.
So this is like beyond entry-level stuff that you were dealing with.
Yes.
At your first rotation. All right.
Yeah.
So keeping the patient information, right? Because we're talking generically here because it's a learning experience. But, what can you tell us about the situation? How'd this come up? Walk us through this.
So I was just working with a patient one day at bedside. He was just doing some exercises in bed. And he turned to me and he said, I'm just ready to die. And I didn't really know what to say. I kind of stood there and I was like, okay. But luckily, he kept going and he kept talking about things so that I didn't really have anything to respond to because I didn't think I had anything of worthy or value to say to this man. And I'm standing there just like, I have no idea. And that just stuck with me all day long. So I came home that day and I was hanging out with my mom and we were just, I told her about it. And then I was like, you know what? I just joined Twitter's PT fam. I just made my own professional account. So let me see if anybody has anything to say, if they do. I wasn't expecting anything. I wasn't expecting anyone to even see it, but I immediately started getting comments and retweets and all these things, and I was like, wow, this is the place to be. So yeah, I got a lot of good feedback from that, and it sparked this conversation today. So
well, I think you touched upon a topic. So first off, I wanted to get this out of the way so I didn't forget, because this is really what I thought. Wow. Student being super brave and like taking a situation that a lot of us, again, in the top of the show, I mentioned, myself included, might be like, wow, I'm just going to file this away. I'm going to pretend like, what do we do, right? Pretend we don't look at it. We don't pretend it doesn't happen. And you went 180 degrees, and I know you already have, but you're going to learn more. And the audience, other people watching, not just listening to this podcast, but people kind of doing what I normally do on Twitter, which is kind of doing that scroll by and now learning from everybody else who chimed in with really, really great advice. But before we move on, before we bring some guests on, because we have some people who were in your comment section to come on the show to talk more about it, why do you think that patient felt comfortable enough with you to say it?
I honestly am not sure. I have worked with that patient a few times before. And I guess I don't know. I honestly don't know why he decided to tell me that, but I'm really grateful he did. I'm glad he was comfortable enough to say that to me, but I wish I had the right words for him at that moment.
Well, I think we're going to go on. Just turn that volume down a little bit on your computer, because I'm hearing myself in your computer, and I am pretty egotistical, but I hear myself a lot. I think, obviously, without knowing this patient's situation, you had a really good rapport. You had to. I mean, that person opened up to you with something really, really personal and was really vulnerable with you. So kudos for building that relationship. And that's a great job. You not knowing what to say, I don't think is a weakness. I what I see it as, you were honest. You didn't know what to say, but then you did something about it, thinking, hey, if this comes up again with this patient, or if this comes up again in another situation, I would like to be armed with something to say. And I think we're gonna figure out that there isn't a right thing to say. There are some different things that you can do. So first of all, kudos on you. You can take a lap and say, yeah, great job on being vulnerable, being honest, and being open on a place where things can devolve. And that's social media. But I am glad that, hashtag PT Twitter and the PT fam came through for you. So we're going to bring some people on, people who dove into your comment section. This is your life, Shelby Miller, where your tweet comes to life. So let's bring one of our guests on right now. Let's do two. We'll do 2 by 2. I'll be like Noah. We're bringing on Talia Pollok and Julie Skzrat. Julie and Talia, how we doing?
Hi. Hey, guys. Thanks for having us.
Great. This is like interactive Twitter, where we just bring people from your comment section on. All right, Talia, Julie, what's your superhero backstories? Where are you in the world and geography of PT, both literally and figuratively? Talia, you go first.
Okay, so I'm Talia. I'm an acute care PT, cardiovascular PT person, and I work at University of Virginia Health System in Charlottesville. I also work I'll be starting at Central Health System here in Lynchburg. So I live in Lynchburg right now, but most of our life and my clinical practice in acute care and critical care was at University of Virginia Health System.
All right,
so that's where a lot of that comes from.
Julie Skzrat, what about you? Where do you treat? Where do you live? Where are you from?
From Philly, live in Charlottesville, Virginia. Teach at Murphy Deming College of Health Sciences at Mary Baldwin University, and practice at VCU's hospital in the acute care setting.
All right. So you guys saw a student reaching out and being super vulnerable about this situation. We'll start with Talia, then Julie, and we're going to bring in some more guests too. Where'd your head go? You jumped in and you provided some advice. First of all, why'd you chime in? Because this isn't something that gets talked about a lot. I think we realize that.
I think that's why I chose to chime in. I get a little self-conscious on social media, but this one spoke directly to me because I recall having, some similar experiences as a young clinician and just feeling so powerless because, we go into this profession to get in there and do a thing. You're action oriented. You want to go in, you want to solve a problem, you want to help out. And then all of a sudden, somebody makes that comment and you kind of just stop in your tracks and go, but wait, this isn't really like my area. What's the right thing to say here? And I think, Jimmy, you said it, there really is there's no right thing to say. I think oftentimes you just have to sit in it and be with them. Because clearly, Shelby, you, again, like Jimmy said, in acute care, when you're seeing patients, for the first time, and they're in a pretty vulnerable position, they're feeling poorly, they've maybe just gotten some bad news, had a big surgery, whatever it is, you have to really build some trust in like 30 seconds. And I think it either happens or it doesn't. And clearly for you, this happened with you, or this person would not have felt safe and saying, you know what, I really think I'm ready. So it just sort of pulled at my heart, because I thought, man, I've been there, and that's yeah, I felt that for you. I felt that for you.
Shelby, it's okay to blush, because I think, Talia just backed me up here, and I like when the guests agree with me, which is you did the right thing, which is long before that comment was made, you had a relationship. Julie, when you saw Shelby send this tweet, why'd you jump in and what'd you say?
Yeah, I think first, Shelby, I applaud you for asking the question and putting yourself out there, because I always say that we do our patients a disservice by not asking questions. And I think being in acute care, especially when the patients are so vulnerable, we do have these episodes that come up where, as Talia said, it's counterintuitive to why we went into this profession. But on the flip side, it is such an honor to help someone die with dignity. So I feel like we have to look across the continuum of life, essentially from birth all the way to the end. We can't just stop when the diagnosis is terminal, if that makes sense. So we do have a role at the end of life as well.
Yeah, I think well put. Some more people from Shelby's comment section. Again, I told you it was like real life Twitter here, Shelby. They're coming to life. Let's bring in Megan Eldridge and Sharon Gorman. Ladies, welcome to the program. You guys were also kind of lurking there on PT Twitter, and you chimed in as well. Megan, when you saw Shelby's tweet, what went through your mind?
I actually think that it happened to me too. Like that same time frame that you asked on Twitter. And I've only been working in acute care for 7 months now, so I'm fairly fresh to acute care. I worked in outpatient for about 1.5 years, so I didn't really have like a patient tell me, that they were ready to die. But that actually did happen to me. And honestly, Shelby, I think you did the best that you could do, because there is really not an answer to that. I think that when we talk about death, it's not really something that people want to talk about, even though it's unfortunately a guarantee. And so it's important that we have those conversations. I also think that they probably felt comfortable with you, one, because of rapport, and two, because honestly, PTs are the ones that spend the most times with the patient. Yeah. So we get to be their best friend while they're in the hospital. And I think that that's one unique thing about physical therapists that we get to do. And honestly, that's why I really like acute care. So
that's great.
I wanted to answer your question because I understood, because that happened to me too. And you being a student, it's just kind of like, whoa, especially second year. I didn't know you were second year. That's like fresh. So, I mean, that didn't happen to me until I was almost 2 years out. And I still didn't know how to answer that. But you definitely want to ask. Asking Twitter was awesome. That was such a great thing to do. I typically go ask my manager, who's been doing this for 10 years. So she will know exactly what to do in that situation. But that's kind of why I came to, you're answering your question, because I wanted you to know that is something that happens. And there's also therapists out there who, have difficulty answering that question too. No matter where you are, if you're a student or if you're 10 years out, I don't know if there's ever a time that you can answer that. And also in school, I don't think we're taught how to talk about that. We're taught what to do in palliative care, but not really the psychological component.
And that's a big component. And when Megan said that, I watched Sharon Gorman from APTA's acute care section, her face all lit all up, right? So when you hear Megan say that, hey, I think in PT school, we're not really taught about this. What did you chime in with in terms of what resonated with you with Shelby's tweet?
So part of the reason I chimed in is actually where I teach at Samuel Merritt. I have carved out at least a few hours to have this discussion with our students. It's not enough time. And it's it came from a place of students would come to me after a clinical going, oh my God, this happened and I don't know what to do about it. And then we'd have a discussion just one-on-one. And I'm like, we need to share this. I've also done a talk that I do occasionally, and I did it for our state conference one year, kind of as a TED talk about how, death and dying. It's not something we're taught, and it's something everything in society tells you to not talk about. And it's so weirdly ironic because it's the one thing every single one of us have in common. Yeah. Everybody. Not everybody gets married. Not everybody has kids. Not everybody owns pets. Not everybody, lives to old age. Every single one of us is going to die. And we are so afraid as a culture to even say that out loud that I was like, here's an opportunity for me to, just get in on this thing that I think is so important for people. And this goes back to when I was a student. If you've ever seen an episode of Scrubs where you've seen somebody crying in a supply closet, that was me. In some of my clinicals, because these hard things were happening, and the messages you sometimes get from your coworkers, and it's not that they intend it, is that we don't talk about this. Mm-hmm. And I didn't know how to process it. And I really felt for you. And I was like, well, maybe I could say something that's helpful in that there's no right thing to say. And usually that question being thrown towards somebody is more an opening to have a conversation instead of to have an answer. It's not a question that has an answer. It's a question that sparks a conversation if you're willing to have the conversation.
I think that's where I started too, because I think I was one of the first people to see your tweet, and I literally retweeted it because I was like, ooh, someone else, that's the retweet, right? It's like, ooh, I would like to see what other people have to say about this because I would like to know the answer, and I do not have it. Another thing is I think that so many people chimed in, a lot of these ladies on the screen included with some other people, which is there is no right answer. I think you all said some form of that, which is I've experienced this, there is no right answer. As somebody who's a physical therapist, but who in a former life, and most of my brain still isn't a radio guy, you did the right thing, I will say this, because you listened. You made space, right? Sometimes as an interviewer, what I'll do is I'll raise my voice at the end of a sentence when I want to leave room and let the other person know it's time for you. Are not only is there time for you, but I am giving you literal and figurative space here to communicate, because sometimes people are just looking for an opportunity to do that. And if someone were to talk too much or to give them exactly what they should do, it's actually not what they're looking to do. They're actually looking to talk. They're not looking to have a problem solved. Their problem is they want to talk. You are solving it by doing exactly what you did, which is listen.
Sometimes the problem is they have no one else they feel like they can talk to. Sometimes families are so invested in following treatment regimens and nobody's had this discussion about what personal preferences might be, and everyone just assumes things. And so a lot of the time I find this is why patients will say this to me or to other therapists is you're kind of this neutral person that I can have thoughts with, and you're not going to judge me, and you're not involved in the decision making. And maybe you're just an echo chamber that I can finally say these things out loud that I'm too afraid to say to my family or my friends or my loved ones.
And you know some stuff, right? They're looking at you, even as, and again, for the podcast audience, I'm using air quotes, even as just a student, they're looking at you like, you know what, I kind of hung out with her once or twice, or, she worked with me. She kind of seems like she knows some stuff. And that's credit, right? I mean, I think, well, kudos on that. Is somebody was comfortable enough to say that to you? Wow. Holy cow. Talia, what do you think that other advice would be, right? Giving room to listen, being there, maintaining that rapport. What else can you arm people with? Because this is, again, something we typically run away from.
Well, I think it's be prepared for it to happen, again, and a bit more. I think one of maybe the comment I made, I think I remember this is the comment, when people are ill, whether it's a terminal diagnosis, whether it's chronic illness, whether it's after a really big surgery, just being in the hospital in general, when they get up and they start to move the first time, there's a lot of reality that happens there. I've heard about the reality of my illness from my physician, from my advanced practice person, from my nurse, and there's this flurry of communication around me. So I have it kind of in my head, but I haven't felt it in my person yet. You know, I'm going to get up and do, and it's going to feel so different than it did, you know, even if I'm better, even if the thing that was there that shouldn't be there is not there anymore, that my brain tumor is out, my blockage in my heart is now open. My body has gone through this kind of a trauma. So you have physical trauma, you have emotional trauma, and I have found, and there's no paper that says this, I'm not really like a paper person. In my experience, I'm so glad Sharon left. In my experience, though, that's when the reality happens, and often kind of we're there witnessing that. And a lot of emotion, a lot of things can be felt. Sometimes it's kind of comes all out, and sometimes it's super reserved, and sometimes it's kind of anywhere in between. I'll never forget a woman, she had gotten her LVAD, and then she got a heart transplant. She was so scared to get up and use her legs just to stand and get to the chair, because let me tell you, sister, she was wired for sound. If we stood up and made it to the chair, it was going to be victorious. And she totally froze. She panicked. And I'd known this lady for 2 years. You know, we went way back to that first VAD. She was like VAD number 3. She got this heart and she said, I can't do it. And she was standing up. She was like totally fine. I can't do it. I can't do it. I can't do it. I said, Sandy, nobody operated on your legs. Just move them. And she looked up and she started laughing and she shimmied her hips and she popped right down in that chair. And all I was doing was holding the stuff. Like, she did her thing. And sometimes it's just the reality of the thing setting in. Yeah. Again, whether it's terminal or not, we're kind of there to bear witness to that. And it's really important, I think, to just sort of sit with somebody. You don't have to always say anything. You can just touch their hand and just be. Mm-hmm. You can just be. And sometimes that is the hardest, most vulnerable thing to do, is just be.
Sounds like, Talia, in that example, you really used that relationship you had built and gave permission where permission didn't need to be. But maybe it felt like she did. Like, hey, I trust her, and if she says, hey, move those legs, we didn't operate on those. And then she did. So she was looking for permission. It's difficult not to bring this word, which is COVID and COVID-19, the situation in the conversation. Julie, let's bring you in here. How's COVID impacted these types of situations involving death? We're in a situation where lots of more people are in situations like this, where they don't know what's going to happen next.
I think talking about death is typically geared towards like the acute care ICU physical therapist. And I think COVID has really been the equalizer in the fact that patients are now getting out of the hospital. So the post-acute care therapist is responsible for the care and building this patient back up. And considering what the patient has been through, not just physically, but also mentally, and the fact that they've been in isolation, they haven't had any family members, they're coming to you post-acute care wearing a mask. There's not a lot of research out there about like long-term effects of this patient population. So I feel like it's really put the entire therapy community on a level playing field, and like we all need to come together to acknowledge what the patient has been through, to give validation to their feelings, and then lean into that uncomfortable conversation, because they very well could have been knocking on death's door, and we need to validate what they were saying.
Yeah. Resources. Let's talk about that. We'll go to Megan. Megan, you mentioned, hey, listen, this happens to me. I go to my mentor who's done it for 10 plus years. What else would you suggest? Places that people can go, things that you've read, things that you've interacted with that made you feel a little better equipped to deal with this situation. Anything come to mind?
Yeah. So right now, when I did go ask about like what resources there are in the hospital, at least, I did ask about like, was there a psychologist or someone that could possibly talk to the patient, especially if they're having these thoughts. And unfortunately, in our hospital, that's not available. But typically, it gets into more of like the resources when a patient might be suicidal or having like suicidal ideation. That's when things get really very, very serious. And that's when you will get like the psychologist, you will get the psychiatric care in that sense with the resources. As far as like patients that are just maybe terminally ill or, have had chronic issues, maybe depressed, that resource, I'm not sure, honestly. And so that's why I'm here. And to ask about resources that you guys might know that I don't know personally to go to. Because I do read, like on APTA, I try to see like what resources there are out there. But as far as like transferring that to the hospital, which would be the benefit, I'm not sure where those resources are at the moment. But I would love to hear them if you guys know.
Well, Sharon, Megan opened the door in terms of APTA, and I saw you nodding there when she brought that up. What resources have you talked about in terms of how you deal with this, bringing the taboo? I did want to bring that word into it, which in the society that I grew up in, at least in my household, we talked about death, but it was kind of whispered, right? I mean, some societies around the world, I think, do a lot better job at talking about this part of life, this end part of life. So what resources in terms of dealing with this or maybe taboos around death have you?
So I have like I know this sounds weird, a really fun website, but some of being comfortable talking about this with patients is you just have to be comfortable talking about it. And if you don't have a cultural background where that's what you did, you need to find ways to just be able to say these words without like getting all choked up or feeling all awkward. And a weirdly really fun one is this website called deathoverdinner.org.
Why not?
And you can kind of pick what the scenario is. Like, are these people you know really well? Are these people you hardly know? Is it a big group? Is it a tiny group? And it kind of just gives you conversation starters that you can use to get people talking about some of these issues. And that can just kind of break the taboo thing. Because if you haven't said words like death and dying, that alone can be the stoppers. Like, I don't even know how to open my mouth about this. So that can be kind of an interesting way. You can play around with it and just look at what the questions are in your own. Mm-hmm. For breaking conversation with patients, or you get approached this way instead of having an answer for this guy, Atul Gawande has these great 5 questions that are in his book. And it kind of gets at what's your understanding of where you are and how sick you are. What are your worries or your fears? What are your goals and priorities? What kind of outcomes do you not want to have happen? Like, where's your point of, I don't want to experience this? And what might you be willing to maybe give up? Like, maybe I could give this up, but this is my stopping point. I don't ever want this to happen. And then kind of my favorite question is the last question. I ask this all the time to my patients. What would a good day look like for you? Because for PTs, 90% of their answer is going to be they want to go do something. They want to spend time with someone. They want to be comfortable. They're going to give you an answer that you can turn into a treatment plan and a goal.
Yeah.
And so like, awesome. I love those questions because then you start to have that conversation, which is usually what they're looking for when they ask questions like that, is to have the conversation. And then this gives you questions where they can tell you what they want and what's important to them.
Yeah. Sharon is actually available to rent to come to your dinner party to actually her up on her Twitter feed. We mentioned a lot of things having to do with patients, right? We put our focus on our patients. I think the current pandemic that we're currently still in has shown a light on taking care of the caregivers. This is going to affect you. Shelby, it affected you enough that you stood up or sat down. I don't know where you were tweeting from, but you were using the phone and you sent that message. So let's go around to our panelists too, who've been dealing with this. And Megan, I know you said you've only been in acute care for 7 months. That's okay. Mm-hmm. You've got experience. We want to hear it. In terms of making sure that the therapists don't get burned out from this, we take care of those caregivers so you can be there. Talia, where does your head go when if you heard a coworker or a student that you were working with was dealing with something like this?
That's a great question. Everybody. Burned out is a great way to describe it. I think tired and fatigued is another thing that we're seeing a lot, not just in our department. The nurses, the housekeeping staff, our physicians. I mean, it's just like, it just keeps going. And when is it going to end? And I think, and this came up kind of over the weekend too, in another webinar, you know, when people are sort of talking to you about your productivity and you're getting that shoved at you and you're just so tired because you're just, you know, you're tired of breathing into a mask. You're tired of watching people decompensate. You're tired of seeing all of the death and dying and the news and all the things. It's just kind of, everybody, I think to a degree, has shut down. But I also have to say that I have seen some amazing acts of resilience when people are able to come together, you know, figuratively speaking, as a staff, as a group, and really talk about, okay, what is it today? What is it today that we can accomplish? What can we actually control out of this day? And typically it's, what can I do when I go in that room? When I go in that room, that's what I can do. That is my contribution. That can be my healing, not just for that patient, but for myself. And I think it's really getting back to the basics and remembering in a time that it's so hard to remember why we are here, because we have people saying, well, we're going to furlough you for a while. You don't need to be here, but oh wait, when you come back, here's your productivity and you have to meet it.
Yeah.
It's this constant battle it's just a constant battle. But I think getting back to the basics and getting back to the foundation will probably set you free. Personally, that's what I have experienced.
Yeah, I think you brought up a few things there that I want to make sure the audience didn't miss, which is focus on what you can do, right? Focus on something that you can control. And the other was it's not just one or the other. Like, you're going to have some really crappy days, and then you're going to be fine. It doesn't mean that everything's better. You know what I mean? Like, it's okay to go up and down in the, well, this sucks department. Realizing that, like, hey, some days I'm going to be super crappy. It doesn't mean I'm bad, right? This is not a guilt or a shame thing. It's a bad situation. Acknowledge that. And I like how you followed it with focus on what you can do. What can you control? Well, I've got 3 more patients to see today, and I'm going to give 100% of what I got left to those people because they need me, and that's what I'm here for. Julie, advice for focusing on the clinician, right? Taking care of the caregiver. We're going to go around this because I think this is an important one that I wanted to leave with the audience.
I think just as we expect our patients to be vulnerable, we have to be vulnerable too. Like, we have to have comfort in saying we are at our breaking point, for lack of a better word. And just echoing what you said, like, this is not us being a bad clinician or a bad person and not being able to handle the weight. This is just the circumstances and being comfortable asking for help, because I think as PTs, we're very, we can handle this, we got this, but I mean, we're only human. Yeah. And so acknowledging that human aspect of what is going on and how we care for our patients, and being cognizant of those around us, because I think it's very easy to say, like, oh, so-and-so is in a bad mood today, or, you know, just tapping into that emotional intelligence of what other people are feeling and going through around you as well. Yeah.
Megan, what do you think in terms of taking care of the caregiver? What advice would you give to someone else, a coworker, a student, for being in the situation for we don't know how long?
Yeah, and we're talking about like just COVID and
COVID or situations, or being around people who where I guess we're really highlighting a situation where the situation is wearing on the caregiver, right? We're the one who's usually providing the relief, but sometimes it wears on us.
Yeah. Yeah. So, you know, as a coworker or someone to come to me and talking about, like, this is a hard time. I think that this is so, like, unknown, and this is so different, that it's just hard to know what to say and what to do. Yeah. Burnout is real, and it does happen to all of us in healthcare. And I think at the beginning of the pandemic, it did, especially for physical therapists, it felt like we were disposable because there was a lot of, like, furlough. I got furloughed, by the way. So, you know, you feel like I did this to help people, but we're in the middle of a pandemic and I'm being just kind of tossed because of what, And so that's hard mentally to go through. Yeah. And it's hard to also help someone else when you're going through that too. Right. But I think that talking about it is important because we, as human beings, we want to be tough. And like you were saying, as physical therapists, we want to be tough. We want to act like we can do everything because we're superhuman. But at the end of the day, we are human. So you need to talk about these things with people. You need to talk about these things with the right people. If things get to a certain point, you need to go to the correct people to get the help that you need. If that is from a counselor, if that is from a psychologist, psychiatrist, whatever you need to do to help yourself, you need to do that. Make sure you're having good, coping mechanisms, and that you're doing the best that you can. You can't do everything, even though you want to. You just can't. Put your mask on first kind of mentality, right? Yeah. Put your mask first and do what you can do. And that's how I've kind of gone through this time because it's just unprecedented. And unfortunately, COVID is so unpredictable, especially with our patients. If you're treating COVID patients, one day they're fine and one day they're not. Yeah. And that is hard to watch too. So as a human, as Megan outlined right there, the human element in it. Sharon, in terms of making sure you're okay, your coworkers are okay so that you can provide great care.
I'm going to follow up on what Megan said. Know your people. Yeah. Know your people, know your resources. Maybe that's counseling. Maybe that's having someone professional to talk to, but maybe it's just who have you curated on social media? I'm sorry. I was starting to get so upset seeing pictures of people in groups without masks that was burning. So you know what? Mute, unfriend, 30-day snooze. I don't have room right now in my life to get mad at people that I thought would understand how hard some of us are working and what sacrifice many of us are going through. And honestly, I don't have time for it. Yeah. And I have felt so much better. And it was really hard the first few times. And now I'm just nope, sleep for 30 days, gonna mute you. You are in charge of what you need to take in, and you don't have to stand there and get yelled at by the universe when you're already on the edge. You don't deserve that. So, don't do it. Don't let it happen. Everyone's oh, well, what about? I'm you're in control. It's your phone and it's your friends list and it's your Twitter feed. Yes. Be the brave person and, figure out what you need to do for you. Yeah. It's not selfish. It's self-preservation. Oof. I like that moment.
Drop moment.
Yeah. I don't owe you the argument you came here to have was a phrase that I forget who I learned it from a year ago or so, but I throw that out a lot in real life or on social media. And it saves you a lot. I would throw something in here for the situation, Shelby, from from a complete interview perspective. If you didn't know what to say, sometimes just stating a fact and being quiet. So it's the question without ever asking a question. And then leaving room, as we mentioned before, which is it's a real hard time. What you just did was you laid something down on the table and then you kind of backed away and you were you pointed at it, right? There's a lot going on. That's not a question, but it actually invites a response, which is actually what you're not looking for an answer. You're trying to continue a conversation. And when you don't know what to say, this is how I continue most conversations. I will literally just state a fact, right? This is a really, really difficult situation, right?
Right.
And then just let them fill in the blanks. Anything we didn't cover that you guys would want to get into? Anything we didn't throw out there? I mean, this is an important topic. Sharon, go.
I've got a really quick one because we did mention that sometimes these places can come from depression in our patients or suicidal ideation. So just make sure there's lots of different easy ways that consist of 2 questions to screen for depression. And you don't have to diagnose it. You don't have to treat it. That's not your job as a PT. Your job as a PT is to recognize it and refer somebody. So figure out what 2-question survey you want to use, whether it's the patient health questionnaire to whatever. There's about 3 or 4 really validated 2-question screens. And that's all you need to do is ask them those questions and screen for it and then make a referral if it's appropriate. You don't have to get dragged into trying to have a counseling session with your patients. That's not your job. Recognize you work in a team and that's not your area of expertise, which is okay. But if you see it or you think you see it or you recognize it, you know, you can always start with maybe those questions if you don't know anything else to ask. And like, okay, is this really serious, or is this, it's a very emotional time and things are really rough and you've been through a bad patch of health issues?
Leverage that relationship that we were just talking about. And if you can ask a couple questions that are validated, right, to make sure to screen for that, man, that is a powerful situation. The questions are only good if you have the relationship, and the relationship, you can only leverage it if you have the right questions to ask. I like this a lot. I thought it was a good conversation. It shed some light for me. You guys ready to do 3 questions? You ready for that? Doesn't matter. We're doing it. 3 questions.
We do it anyway. I was like,
All right, 3 questions brought to you by our friends at Fusion Medical Staffing. As a travel PT or travel physical therapist assistant, you get to decide where, when, and how you do what you do best, which is provide quality care to your patients, like we're talking about. With a traveler-first mentality means you get full control of your healthcare career so you can create the travel lifestyle you love and, frankly, deserve. And with detailed job transparency, you always want to have the good transparency, you can seriously choose your own adventure. It's your career. Take a hold of it. Start your adventure now at fusionmedstaff.com. That website is fusionmedstaff.com. All right, so 3 questions. First question is a where question. Since we got so many guests, we'll go around the horn quickly. And with 1 or 2 word responses, we're going to go Shelby, Talia, and around the horn. Where, once it's safe to travel, would you like to go in the 50 U.S. states? Shelby, where are you going to go first?
I have always wanted to go to Seattle, so that's where I want to go.
They throw fish around. I'm just saying up on that. So
Coffee, my favorite.
They got great. Talia, where are you going first once it's safe?
Upstate New York to visit my best friend from college.
Why not? Everybody loves upstate. It's the spot. There we go. Drop by for a beer. That's where I live. Julie, where are we headed?
I would go back to Philly to see my family.
There you go. Focus on family. Megan, you're in Georgia now, but where are we headed?
San Diego, California.
Yeah, San Diego. And Sharon, where are you going?
I would like to leave the country, but since you're forcing me to stay in the United States, I think I want to go to Washington, D.C.
Yeah.
I haven't been there in a while.
It's pretty gorgeous there.
It's a great time.
It's a PT school just across the river there. It's great. Second question, we'll go same order. It's a what question. What's something you've read, listened to, or watched, book, movie, podcast, that you just think the audience would get value from? It does not have to be PT related, but it can be. What do you got?
The book I'm reading right now is called Why We Sleep by Matthew Miller, and it's a really good book. And I think it's really insightful for physical therapists because it's something that we often overlook is sleep quality. And so you get a really good idea of the benefits behind it.
Yeah. Spoiler alert, Why We Sleep. I get sleepy sometimes. I get tired. Talia, what do you got for your what?
I have so enjoyed, for a mental break, Smartless podcast with Jason Bateman, Sean Hayes, and Will Arnett.
How do you not love all those guys?
I mean, and all together, during my little commute, it just makes my heart so happy.
Have you seen the Mumford and Sons video?
Oh, yes.
The Hopeless Wanderer?
No,
go to YouTube. Just go to YouTube. Don't listen to this podcast anymore. And just look up Hopeless Wanderer Mumford and Sons video. And then you're welcome. All right, Julie.
I like that song. That song.
The music video, just watch it. That's all I'm going to say.
Okay.
Julie, what do you got for us? What's your what?
I will say When Breath Becomes Air by Paul Canaletti. That being a cardiopulmonary person, I just love hearing his story and the patient perspective.
Yeah, that's come up a lot on the show for the book. Megan, what do you got?
So have y'all heard of the Calm app?
The Calm app? No.
Yeah. So it's like an app that helps you kind of meditate and sleep. And if you have an American Express, which I think that's over now, but I think it was December 31st, 2020. If you had an American Express, it's free for a year. And it's like expensive. So I have that. and I use it. And they have a great How Do You Sleep by Sam Smith, like meditation thing. It puts me right to sleep. I'm just saying. It's awesome.
That's all I got to say. Sharon, what do you got for us?
I watched this program on Hulu this weekend called In and of Itself. It was an off-Broadway kind of one-man show. I refuse to try and explain it or pigeonhole it. It was amazing and blew my mind, and all the emotions and fun and funny and touching. Hulu, In and of Itself. Can't say enough. You can thank me later.
All right. Thank you. Last question on 3 questions, the who question, right? We begin and end with people. Who is someone the audience should know more about? On purpose, I leave it open and ambiguous. What do you got?
All right, I got to do a shout out to Clarkson University. Leslie Russick is one of our instructors, and she has done some amazing things in research on chronic pain and Ehlers-Danlos syndrome. She is the smartest person I have ever known and will probably ever know. And I think everyone should be friends with her. She's perfect. She's awesome. I love her.
And you just got 10 extra points in your next quiz. That was so smart of you. That's so smart of you. Talia, who should we?
Dr. Gary Gellert is a phenomenal PT that I work with here in Lynchburg, Virginia. He has basically made over the ICU practice there. We share a brain a little bit. His half's a lot smarter than my half, or bigger than my half. But he has been in the COVID unit since the beginning, and he's created an entire practice, just for this area, which is pretty COVID heavy right now. So he's an amazing person. He should be on PT Pintcast. He should be everywhere.
I know a guy. I'll get him on. This is why I love this question, is because when people gush about people they like, I just sit here and just like, this is great. And yeah, it makes for great future guests. Julie, who should we know about?
Okay, so as a Flyers fan, I should not recommend him because he's a Penguins fan. But I'm going to say Dr. Sean Greek. Okay. So he's based in Allentown, and he's an academician that just got his PhD and currently very involved in social determinants of health and health literacy and population health. And I just think I've learned so much from him. And especially nowadays, like, this is such an opportune time to really expand physical therapy and how we deliver services. So Sean Greek.
I like how you reach across the hockey aisle. You reach across the red line.
Across the state.
Yeah. Megan, who's your who?
So my who is Dr. Amber Lowe. She is actually my former manager in my outpatient clinic. She's now just started her new cash-based PT, and she helps runners in Houston, help with them not having pain with running. She's OCS, she's fellow trained, like, she knows. She's one of the smartest people that I know, and I know she can be very, very helpful to people in the Houston area. So if you're looking for a physical therapist in the Houston area, she's your girl.
You got it. All right, Sharon, no pressure, but you're closing here. Who's your who?
I'm going to go with another social determinant of health PT hero, with Dr. Todd Davenport from the University of the Pacific, out here West Coast, best coast. I'll get that in. Great follow on Twitter. You'll get everything and the kitchen sink.
Yeah.
Yep.
I just learned from him that he ran his entire last season of track with a broken fibula. I don't know why, but I just wanted to throw that in.
Oh, God.
It hurts, apparently.
He's one of the most gracious people, by the way. I have to say, he's so gracious and kind. So
I like it.
Those are the kind I don't think I know him, but I think I follow him on Twitter.
Well, now you do. And this episode is not a culmination of, and now you know these people from Twitter. Yeah. Nothing will be. That's 3 questions from our friends at Fusion Medical Staffing. Check them online again, fusionmedstaff.com. Last thing we do on the show is the parting shot. Parting shot brought to you by our friends from the Academy of Orthopedic Physical Therapy. We want to hit that of. They are the Academy of. They're it. Orthopedics. If you're looking to use maybe some downtime, maybe you can't travel or something like that for some odd reason, and you're thinking about taking the OCS exam, current concepts of orthopedic physical therapy, that can get you there. That can be your guide. All right. So you start out and you're like, I don't know. I feel like I want to take this on, but I'm not sure how this works. Listen, their reading list alone you're going to want to dive in. So Current Concepts of Orthopedic PT is the guide to take you there. You follow the steps. You focus on this. It's made from the leaders in orthopedic PT all the way to that OCS and beyond. Really, the point isn't just to get the OCS. It's to help your patients. And this will do it because they are the Academy of Orthopedic Physical Therapy. Find them online at orthopt.org. Again, that is orthopt.org. Parting shot. Shelby, you're going to go last. This is your final exam. It's going to be kind of like, what did you learn? So, Talia, last thing you want to leave with the audience, your parting shot, kind of your mic drop moment. We'll go around, and Shelby, you're going last. No pressure. Talia, you're up. What do you got for us?
This is a Brene Brown because I love her. Given our conversation and the current state of things, sometimes the bravest and most important thing you can do is just show up.
Heavy.
Yeah.
That is awesome. Well done. All right, Julie, your parting shot. What do you got for us today?
So for you, today is ordinary, but for your patient and their family, it's extraordinary. So be patient.
Man, you guys came out slinging. You guys were ready. Megan, parting shot. What do you got for us?
I don't have anything as like elegant as you guys. I would just like to say I appreciate you guys for letting me be here. This was a great conversation. And just remember to always listen to your patients and just remember you're human.
Listen to your patients. That's it right there, right? That's the first thing. That's the last thing we should be doing. Sharon, you've done this before. What's your parting shot for us today?
One of my favorite little quotes that someday when I can get a tattoo, I'm going to get tattooed on me finally, is speak the truth even if your voice shakes.
Ooh. All right, Shelby, this began with a tweet, right? And then you got information, you got knowledge, you got support. PT Twitter came to your aid. And then we had this conversation, and now everybody gets to learn from not only the tweet, but the podcast. Your parting shot, what do you got for us today?
I just want to thank everyone for responding to my tweet and for showing up tonight. What I learned is that basically it supports my ideals of that just because we're physical therapists doesn't mean we just treat the physical. We also treat the emotional.
How'd she do? What do you guys think? Yeah, I agree.
Beautiful.
Well done. I like that a lot. Guys, thanks for being brave enough and bold enough to ask the question and then kind enough and paying attention enough to answer. You guys amongst many on hashtag PT Twitter. Join in. It's not all just people pointing fingers. Sometimes some really great, amazing things happen. So thank you guys for doing that. We learned a lot. This was awesome. Cheers.
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 Cheers.